Hey Mo,
Hey, Ricky.
the doctor is in.
Yes, yes, we are. And even before Heart Health Month, it's good for us to talk about this because it's the top of the year and everything is sort of top of mind about our health. But we got to talk about, cardiac events, heart disease, heart symptoms. And the term is cardiotoxicity, right? It's a long word for bad stuff that happens to your heart as a result of cancer treatment. Because I don't know how many people know that that's a side effect that can happen. And we'll talk
Yeah,
about it enough.
we
Mhm.
don't we don't talk about it and we don't hear about it and we have an expert. We
We
found
do.
another badass black woman to help us figure this out, right? So we're so glad to have you, Dr. Anithya. And you can introduce yourself because there are too many words for me to remember.
Thank you. Yeah. So my name is Arnithia. I am an assistant professor at VCU, Virginia Commonwealth University. I'm here in Richmond, Virginia, and been here for about 20 years. So I'm really glad to be here.
You're
This
too
is an
young for
important topic.
that. You're too young for that.
Thank you. I appreciate you. But I definitely, I've been here for a long time. So I'm glad y'all have me up here because you're right. It is an important topic that we don't talk enough about. So I'm ready to dive in.
Great, 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 great. So where should we even start? And Mo, I know where you want to start. So you go.
Well, let's set it up, right? Like how many people actually have issues during chemotherapy or cardiotoxicity, as we call it. And the studies show that as few as 30% up to 80% of people will have some level of heart injury that happens as a result of cancer treatment, not just chemo, but throughout
Mhm.
the whole process. And a lot of that ends up being reversible, but some of it isn't. And even if it does reverse on its own, you should still know and be aware that your heart can be impacted because
Mhm.
during
Yeah.
this thing, during this time, you're thinking about your cancer, right? You think about your family, you
Right.
think about your
Yep.
finances, all these things, but you're not really thinking about your heart or your thyroid or your diabetes or all the other life stuff that's happening when cancer sucks all the air out of the room. So I
Mhm.
think it's important for us to sort of talk about what research is being done and why did this get on people's radar and what we're doing about it. So Arnita, I got to start with you because
Okay.
in addition to knowing that all that you do academically, we want to know why you do what you do. So what's your why?
Okay. So I actually just got in this field probably about 5 or 6 years ago, and I stumbled on it. Um, I was looking for a postdoc. So what was I going to do after I got my PhD, and how was I going to use it? And I met this brilliant researcher here. She had just gotten here from Georgetown, Dr. Vanessa Shepard, and she was looking for a postdoc. And we met, and she was like, "Come on!" And she said, "I'm gonna teach you everything breast cancer, everything disparities." And at that point, we weren't doing anything with the heart per se, but she does survivorship work. So my big why, there was this trial that she developed called Stepping Stone, and it's survivors taking on nutrition and exercise. It was for Black women who had breast cancer, were overweight or obesity, and it was tailored exercise, tailored nutrition. And one of the things we did when they came in, we were able to assess their what we call cardiorespiratory fitness, so how their heart was working. So they did that, and once a couple of women came in, the person we were working with, he sent us this email. I still have it to this day as a screenshot, and it was like, well, after a couple of weeks, we're seeing improvements in their heart, in their fitness. I'm like, okay, good. But he was like, even with the weeks of improvements, they're still in the poor range. And he what really stopped Dr. Shepard, me and Dr. Shepard, was he's like, some of them are worse off than our heart failure patients that are coming in here for trials. And I was like, okay. So now we're talking about women who are breast cancer survivors. These women are all finished active treatment, some of them 10 years down from treatment. And they have heart issues, and no one knows. You're walking around, you're feeling just fine. But when we start to take a deeper look, we see that this is the issue. So that right there, that is definitely part of my why, especially because I knew some of the women on this trial. So it became very scary. I realized Dr. Shepard and I were talking. I was like, we're like, this is an important thing. And then we just started diving in from there. So that's kind of how all of that got started. And then from there, it's like, what can we do? What can we find out about it? There wasn't much out there. So one of the things we were kind of chatting about before we started was the fact that we quickly learned that there's a disparity. There's a racial disparity, which we tend to see a lot, unfortunately. And so we were able to do some work just looking at all the data, all the studies that were published out there, and we found that Black women were 3 times more likely to develop heart issues after breast cancer when compared to white women.
Wow. Say that again. Say that again.
Yeah. Yes. So Black women are up to 3 times more likely to develop heart issues when compared to white women, Black women and white women with breast cancer. Yeah. And then I already know the question.
Talk a lot about, I'm sorry. We talk
No, I was just going to say, if anybody's asking why, we don't know yet. So we can unpack that a little bit.
But that's what we say. Black breast cancer is a different disease.
Yes.
It is a different disease. And we're seeing it in so many ways, in so much science. And now here's another validation of it.
Yeah.
I think it's good to look at the underlying conditions too, because whether or not these women had heart disease or early heart disease or family histories of heart disease, those are two, Bricky, when we talk about knowing her story, those are things that are really important for us to know, because if you have that family history, if you have underlying conditions, and then your doctor puts you on that standard dose of chemotherapy, it may be that it's too toxic. It may be, right, that there's enzymes and other things in the way our body processes things, right, that makes for more side effects and more toxicity. And we see that with things like neuropathy, where we tend to have a worse experience with neuropathy from the same dose of drugs. So it's a very interesting field, but it's something to, how did they develop this idea or develop this study? And tell us a little bit more about it, if you would.
Yeah, so what we did was like a review, right? So we just went on and searched PubMed to look at all the articles, anything that published anything about Black women and white women. The interesting thing, though, that we found, because sometimes you brought up some good points, like what about some chronic conditions that may contribute to why we see heart disease? All the analysis that we found considered things like hypertension, considered things like diabetes. Many of these data sets did not have family history. But when you think about just those 2 that I mentioned, and consider BMI. Okay, so your body mass index, whether you have obesity, overweight, etc. If we, even in those analyses, if we consider all those things, we still saw a difference. So it's not like, okay, once we consider women hypertension, then we don't see the difference anymore. No. So what that makes individuals like myself think is there's something else there that we're not capturing. And I already have an idea what it may be. But there's some things there that we're not looking at. That is why we're seeing these differences.
Wow.
Do we skip ahead to the punchline and ask what your sneaking suspicion is?
Yeah.
Are you able to share?
I don't think it's going to be a surprise to you all. I mean, I think, I'm working with one of my colleagues here. I think there's some hypotheses around stress. I think there are some things to deal with, discrimination while in healthcare. So while you're receiving treatment, even after it, your everyday discrimination, maybe how you even cope, the type of, one of the things we looked at one time is maybe, Black women are being prescribed medication to protect their heart at the same rate. And so in our analysis, we didn't see a difference in race. So we had a small subset of women, but that may still be something, the type of protective heart medication people are given. So there's a lot. I feel like there's a lot there left to unpack.
It is.
I don't know that I was given any heart medications when I was on chemo.
So and there are, though. Go ahead.
Oh no. So let's talk about that, because I'm always quick to jump into the disparity. That's what I do. But we'll talk about it overall. So I was recommended to go read the guidelines. I was like, let me read these guidelines for what we call cardio-oncology, so the field of heart and cancer. And so there are a lot of recommendations there. Now, we're going to talk breast cancer specifically. For women who have HER2 positive breast cancer and they're prescribed, trastuzumab, Herceptin, whatever you want to call it, there's a schedule. They're supposed to receive echoes or imaging of their heart before they start, every 3 months throughout the treatment. Okay. That is a guideline that's well known, well established. If you talk to women who had it, they'll be like, oh yeah, I remember I got them every 3 months. Anthracyclines, doxorubicin, adriamycin, we'll use all the names. When you talk to it, there's not clinical guidelines for making sure they get assessments the same way. There's typically a risk assessment done before you start to try to understand if you're at risk of developing heart disease. I have my feelings about that. There are recommendations for survivors that once you finish treatment, if you're considered like low risk at this point, so you're not showing any signs or symptoms of like some kind of heart issue, that you should get an annual evaluation. That's a recommendation. It's not a guideline yet. So it's a recommendation that you should get maybe an echo and some blood work done, and like, you know, just an assessment with your physician. I mean, I'm sure you could. I haven't heard too many women that said that has occurred for them. And like I said, it's a recommendation.
Mm-hmm. So that brings up a good point, because the field of cardio-oncology is a new one, and cardiologists have followed along and been supportive and seen these patients, but it really has been left up to the oncologist to figure out who needs to get what testing. And there's a disparity there, right? There's that word again.
Yeah.
And the disparity exists, one, in the setting of the programs that actually have cardiologists with cancer expertise. Right. Yep. They're experts in treating the heart effects of cancer drugs.
Yep.
And two, even getting all those tests, getting all the echoes, getting all the studies that you need, it isn't always happening in the community setting. And patients don't always go for it because you already feel crappy when you're on chemo and you're just trying to get through certain things. And so it's not necessarily enforced, I'll say, right? The importance of it. It might be one more study you got to get, and you're like, well, I already missed work twice this week, and I already got to do da-da-da-da, and I'm already up to my eyeballs in this. Why do I need this other scan of my heart? I'm treating my cancer. And so the importance of it isn't always stressed. I know we're having a tumor board and a conversation about it as well, because we got a lot of cardiologists, but how many of them are really experts in treating, right, the cancer-related side effects on the heart? And we're the ones at those community centers.
Right.
Yeah, so one of the points I will make, I'm glad you brought up community settings. So like I realize here where I am, you know, we in a lot of academic medical centers, so centers that are attached to universities, schools of medicine, you know, here we have oncology, we have cardiology, and we have cardio-oncology. We have a whole session of physicians who are trained in heart and cancer. And so, like you said, it's an emerging field. But when you start to look in community settings, that's not the typical makeup that we see.
No. I know you don't even see breast oncologists sometimes at community centers. You see oncologists that do everything. So
it's true. Right? Surgeons too, right? It's hard to find specialized surgeons who just do breast cancer surgery as well. 80% of cancer surgery done by general surgeons in this country.
Is it really, Mo? 80%
of breast cancer surgery, yep. Wow. And those numbers are changing as we graduate more fellows and more people who are trained in it, but there have to be more training slots for it, right? So yeah, a lot of it's still done by folks who don't specialize. And it's not to say that they don't do good care, but it's hard to find the consistency and also the research and also the specialization that makes you stop and say, okay, this is an African-American woman, this Black woman might have some other risk factors. Let me dig a little bit deeper. Right, as opposed to just guideline, and keep it pushing.
Yep.
Well, we know that's not happening, Mo. We know that's not happening, and we know that people aren't looking at our breast cancer differently, and they need to be. So,
and it goes beyond chemo too, right? We got a question in the chat here, right? What are your thoughts on things like Arimidex? We give people a pill to block your estrogen, right, to prevent your cancer from coming back, but does that cancer estrogen blocking drug cause side effects as well? And the answer is yes. Yes, it can. And I'm really glad, Sheila, you put that in the chat, because something like, I want to say use of 4 years or more of an aromatase inhibitor is associated with what we call ischemic heart disease, arrhythmias. You can have irregularities in your rate and things. Doc, you talk about it more. You're the expert on this, but tell us about these oral medications.
So that's interesting, because I was about to ask you a question. So there have been, I'm going to say that for a while, some of these data were controversial. Okay. So when it came down to aromatase inhibitors, they usually looked at aromatase inhibitors versus tamoxifen, and to see if there was a difference in between those two of women developing heart disease. So for a while, it looked like AIs they were like, oh yeah, they will contribute to heart disease. Then I remember there was a paper that was published probably in the last like 3 years. They were like, ooh, is it really that AIs cause heart disease at a higher rate Or is it that tamoxifen may be cardioprotective? So then things got a little, yeah.
Wow.
So that was when there was
So
a comparison.
cardioprotective meaning tamoxifen was helping
Like
you?
it's like it was going to protect, like, so because they were comparing the two groups, AI versus tamoxifen, maybe it wasn't your risk was higher on AI. Maybe it was that tamoxifen somehow like protected the heart at a more of a rate. I think now, like that was like 3 years or so ago. I think now, like some of the data are leaning towards what Dr. Mo said, that now we're looking at AIs like, okay, and some of the papers that I've read, they're like AIs maybe like contribute to cardiotoxicity or cardiac issues. I still don't feel like there's enough. I believe it. Let's put it out there. I don't think there's enough out there yet on AIs. There's such a big focus on anthracyclines, doxorubicin, andromycin, and HER2 targeted therapies that I feel like, and I think data are showing is that there are more therapies out there that can cause heart issues. And we just haven't really dug down deep into them yet.
Yep. So let's break it down for our folks. Aromatase inhibitors are what she's saying are AIs.
Mm-hmm.
And those are to help you prevent your cancer from coming back.
Yep,
So,
they're estrogen blockers, you know,
yeah.
and they're the type of estrogen blocker that's appropriate for women who have already gone through menopause. So your ovaries aren't making any more estrogen, but your body, you still have circulating estrogen levels. So how do we block that? Because estrogen is the gasoline that makes the car go, right? So we want to take away, empty out the tank so that new cancers don't grow. So, but there's side effects of estrogen blockers. And I think this is where it gets a little bit tricky, Dr. Arnitha, because, you know, when we look at what happens to people who are taking aromatase inhibitors, sometimes there can be fatigue. There can be a decrease in activity level. There can be some weight gain. There can, right? Like it's getting multifactorial here as to why a person might have some heart issues also on these pills, you know, but I think that we really do need to look at it more because we have thought that these pills were kind of a saving grace, right? Everybody wants a pill to prevent recurrence, and the people with TNBC are like, "Well, how come I don't have a pill to prevent my recurrence?"
You don't have a drug, right?
The people on it don't want it, and you know, it's
that's
6 in one hand and half a dozen in the other. But there are things that we need to watch out for, and I think that's the take-home message for people watching: is that, you know, don't just ask your doctor, well, what are the major side effects? But is there anything else I should watch out for when I get home? And you should know your history and know your family history. Because if there's a history of heart disease and other things, you need to have the conversation so you know what to look out for.
Yeah. All right. So here we are. So I'm a patient.
Mm-hmm.
I'm on an aromatase inhibitor. I'm 3 years out or whatever, and I'm starting to feel sluggish, and I'm starting to feel fatigue, and I'm starting to feel a little strange.
Mm-hmm.
What do I do?
Well, you know, it's like we always say, you need to go and talk to your physician about it. Here's the thing though, so when you say that, that is your recognition of it, and
right,
and not
that's how I feel,
and not
right.
But I think here's the thing. I think one of the things that women in general, and certainly women after cancer and treatment, is a recognition and like knowing yourself, like, and not always attributing things to, because I, you know, one of the great things I love about my work is I get to interview women and like capture all this data. And so there have been times I've interviewed about this very topic, and they're like, yeah, but I knew I had cancer. And so, you know, I just felt like, oh, you know,
I
this
thought
is
it was
just
chemo. I
comfort.
thought it was cancer. I thought it was
right. And there's no, and my feeling is, yeah, talk to somebody, because there's nothing too small. So if you're like, oh, you know, I'll never forget this one woman's like, yeah, at one point I was, you know, I was in the bed and I was asleep. And then it got to the point where I couldn't lay down flat anymore. So then I just sleep in my recliner. Now, and then her question was, should I talk to my doctor about that? You absolutely should. But so often, and this is really in women in general, we'll be like, oh, you know, got all these things going on. This is happening. I'll figure it out and I'll keep it moving. And so she was just sleeping in her recliner. And so to your point, Ricky, yeah, if you're starting to feel, you're like, I don't feel quite like myself. Even if it's just I'm feeling a little winded, or I'm more tired than usual, then you need to talk to your physician about that. Absolutely. Because it could be something as what we consider as subtle as like, oh, I get a little bit tired when I walk up the stairs now. I'm getting old. I mean, that's what we do though.
Right.
And then but it might not just be that.
Right. Right.
And I think the other part of it is that, you know, we may not present with typical symptoms. So it's always okay to say, is this something I should expect? I'm having these symptoms. And I spend a lot of time reassuring patients. Yeah, after radiation, this is how it's normal to feel this way. It's normal. But if you don't bring it up, you're going to be wondering in the back of your mind, or you're going to be assuming that it's normal. But studies show that, you know, Black women, only 39% of Black women are aware that chest pain is a sign of a heart attack, but they might not have those symptoms. It might not present as chest pain,
Right.
or it may present as shortness of breath, but you might not have the classic symptoms of things. So you really do have to, as much as you can, even if you're not feeling well, learn to listen to that body. There's no better time to learn to listen to your body than when you're, you know, in chemotherapy or under cancer treatment.
Mm-hmm.
Well, you really do have to know your body, and we know it better than doctors. And I think that's where we talk to so many women who are in a quandary, or they go to the doctor with something like this and get dismissed, even when they're in treatment. Oh, that's to be expected or whatever. So I think it's, again, though, just having a keen awareness of, wait a minute, this does not feel right. And you have to recognize that and go get attention. You know what I mean? And you may have to even, you know, demand attention from your doctor than if they're trying to brush it off. But a little thing like that. And so let's talk about this. And we talked a little bit before the show, but what are the symptoms of heart disease? Like, how do I know I could have it?
So it could be that you're getting extremely tired. It could be that you're starting to feel like, I mean, you think about like some of the heart attack symptoms, that you're starting to feel like your chest is getting tight, or you're feeling pain. It could be that you're experiencing some swelling. So like all of a sudden you're like, I feel like I'm retaining some water. Maybe my ankles, like that may be a sign. Dr. Mo, you're the physician. You can help me out just a little bit.
And it's natural to have some puffiness during chemo because you get a bunch of steroids, and so you feel puffy, right? But if you got swelling in your leg that's not going away, in both legs, you know, you just can't seem to get your breath, your energy level doesn't feel right, your heart is racing, or you're having, you know, chest pain, palpitations, things like that, it's not normal. And even if it's from the drug, that means the drug might be too strong, and you still should bring it up. You shouldn't just say, oh, I guess this is how it's going to be. And you should talk to somebody so that, again, you can know what normal is. And that can mean as much as even picking up the phone and talking, calling your nurse, call a nurse practitioner, do a televisit even, you know, and just kind of start running these symptoms. Say, okay, you know what, after cycle 1, here's how I felt. After cycle 2, I felt like this. I'm on my 3rd cycle, and here's where I am. And something doesn't feel right. And so I think that kind of conversation should then spark some action. You know, okay, Ms. Jones, if this doesn't go away in a couple of days, you know, give us a call. We need to get you in. Let's get an EKG at least. You know, we don't have to put you through the $1 million workup, but at least let's just check your heart. Let's draw a little bit of blood work because you got to come in for your labs anyway, right? But put it on somebody's radar for sure, and keep that tab of how you're feeling so that you can be able to look back and say, no, this is different.
Yeah, we have Stephanie in the comments is talking about high blood pressure. She's asking,
I'm so glad.
Medications are too high, but if you're on high blood pressure medication in addition to your chemo, then that probably is another thing to think about.
So let's talk about, I'm glad somebody brought up high blood pressure, because so Dr. Mo mentioned the big term, cardiotoxicity. And even I've learned just in my 3-4 years in this particular field that there's so much discrepancy about all these terms. Okay. So they're generally, like, if you talk to a cardiologist, doctor that specifically works on your heart, and they're thinking about cardiotoxicity, they're talking about something called your ejection fraction. So if any of you have had echoes, you probably have heard them talking about your ejection fraction. And that's just the percent, like the way your heart will pump out blood. So they're looking at a certain percentage of how well your heart pumps out blood. But in the big, the scheme of what kind of heart issues you can have after treatment, we talked about heart failure, ejection fraction declining, some cardiomyopathy. But the other one that doesn't get enough is hypertension or high blood pressure. So we know that is something that can occur after your treatment. And that's one of the things our team just looked at. We had this huge data set, nice size data set from our hospital, and we're like, let's look at the risk of developing hypertension after your breast cancer. And I always, like I said, I do disparity. So I'm like, let's look at this, see if there's differences by race. So 45% of women had developed high blood pressure.
After chemo?
After this is chemo. So we consider all chemo, what we consider the cardiotoxic drugs, chemo, the anthracyclines, HER2 targeted therapies. So this group, these are, because I'm interested in like cardiotoxicity. So everyone got a medication that potentially harmed your heart. Everybody in this group. And so
say that again, what percent?
Okay, 45. Okay. Black women overwhelmingly higher risk of hypertension within 1 year of diagnosis of breast cancer. Okay. Unfortunately, I'll be honest, these are hospital data. So I can't look too much into those to see like the why. You know, and again, we talked about some of the things I think contribute to it. We don't have that in the hospital data. Okay. But that is considering people's BMIs. That's considering if they had diabetes or not. That's considering the stage of their breast cancer, even what type of treatments, what type of surgery they had. We still see this huge gap between Black and white women. The other thing that we saw, because not only do I'm interested in racial disparities, but sometimes I'll look at like place where we live. Women that lived in rural areas were more likely to develop hypertension than women that lived in urban areas. Now, that was something we didn't expect. Because we think about hypertension, high blood pressure. A lot of times we think about stress and all. And so I work with a hypertension researcher, and she was like, I was not expecting that. And so now we see that we know there's some women who live in rural areas. Sometimes there's access to care things. They have their own stress that they deal with. And so again, this thing of hypertension, we have to start looking at, because if you can develop hypertension after breast cancer treatment, hypertension is a risk factor for heart disease, for other heart diseases. So then it's like, you know, my team now, like that's one of the areas we're going to focus on. We're just like, let's focus on hypertension.
I love that, because I think people don't realize that there's a connection with hypertension and heart disease that increases your risk for breast cancer as well. Right. Yes. So the inverse is also true. So if you're watching and you're like, yeah, but I don't have breast cancer, this doesn't apply to me. You got to talk to your peoples, because it does, for a lot of different reasons. And we don't understand all of the reasons why. But what we call coronary artery disease, when those arteries start getting calcified and hard and they get kind of crunchy, that atherosclerosis, that inflammation, I think is really probably what it boils down to. A lot of that impacts your risk for development of cancer too. So yet another reason why, even if you don't have breast cancer, you got to manage things like your blood pressure, because, you know, this concept of wellness extends not only to people who are, you know, recovering in survivorship or thrivership from cancer, but how do we keep cancer from happening? And it has a lot to do with the preventable and chronic illnesses that we know we can control. And then cancer happens and boom, we already had hypertension and we didn't really know, we didn't really take anything for it. Our blood sugar was already a little bit on the cusp of, right now we're giving you all these steroids, making you puffy and making your A1C go up, and you come out of cancer with a lot more stuff than you went in with.
And could it enhance a recurrence? So you're taking, so you have cancer, you do the stuff, you start taking you know, tamoxifen or aromatase inhibitor, and then your blood pressure goes up, you start to get these symptoms. Could that make your cancer come back?
Well, you know, here's the thing that you're talking about, Ricky, is really the question of should you continue taking your treatment. And so that's also a big issue. When we start to look at not even just endocrine therapy, you look at, you know, therapy for HER2 while you're in treatment. And there have been studies that show this, because they're monitoring you. They'll do your echoes. There was a study that came out probably in the last, like, I want to say 6 years or so, that looked at the difference between Black and white women in discontinuing therapy. And they were looking specifically at HER2 targeted therapies. And so we know that being on that stretch, 1 year of that therapy is great for outcomes, but Black women were more likely to develop heart issues, which means they were more likely to have an interruption of their treatment. And so then what does that mean further on for breast cancer outcomes? Same with what you just mentioned. It's like, if you develop hypertension or something, why, then it might be. And even Dr. Mo mentioned that there are a lot of side effects that come with endocrine therapy, some of which are so debilitating. And then it's like, then should I stop my endocrine therapy? Should I pause it? Should I just, you know, what they call sometimes a holiday? Should I take a little break? Should I stop it altogether? And then what does that mean later on?
What does that mean for my cancer recurrence or my cancer outcome? Oh my
And I
goodness.
hate that people feel that catch-22. Like, okay,
Mm-hmm.
if I take the pill, I'm gonna end up
Yeah,
with heart failure and
yeah,
die, or get a
yeah,
recurrence. If I don't take the pill, I'm gonna get a recurrence because I didn't block my estrogen.
yeah.
But what it speaks to, I think, is again knowing your personal medical history. Do you have
Yeah.
any risk factors? Do you have hypertension already that maybe was undiagnosed or
Mm-hmm.
untreated? Two, knowing that family history. Three, and that helps to inform whether or not when you weigh the risk versus the benefit, you go talk to a doctor. They should give you the benefit, and then they should
Right.
weigh it against what are your
Absolutely.
risk factors, and then how will I be monitored? That's the question you got to ask your
Mm-hmm.
doctor. All right, I'm going to try this estrogen blocker, and I tell my patients, listen, the benefit may outweigh the risk. The beauty of a pill, you don't like how you feel, you stop taking it. It's not like a surgery, you can't cut it back on.
Right.
But a pill you
Right.
can stop taking, right? A
Yeah.
medication we can titrate that. So maybe you go down that road. But then
Mm-hmm.
the questions are, what am I watching for? How often am I being monitored for these things? Anything else I should know, doc? Right? And start thinking down the road a little bit. And the last point I want to make is that it really speaks to the need to move your body, to
Mm-hmm.
get
Yeah,
your
yeah,
conditions as best as you can to start to
yeah,
manage those things through wellness, because
yeah.
every medication has side effects, and
Yep.
the only way to really reduce your risk, get that blood pressure under control, get that A1C under control, and those pills don't make you feel like
Your
moving.
body.
I know it. I know they don't. They make you
Yeah.
have achy joints, and they make you tired, and everything we do makes you tired, but you
Mm-hmm.
really got to push to get to that point where you are maximizing your wellness. And I think
Yep.
that's a path forward for us, because and it's so hard after cancer happens, but you got to push.
Yeah.
Gotta
No,
push.
you.
You gotta move your body, and you gotta I think though that being on chemo does give you this sort of heightened awareness of your body, because you feel like you're out of control. You have no control over
Mm-hmm.
your body. And so you have all these sensations that you've never had before. It's kind of like being pregnant too. I'm like, but you sort of have this new thing, and like you start to question any tingle. Like, is it,
Mm-hmm.
I remember the first time I had like bone pain from my bones regenerating after chemo. But I thought I had cancer. I thought my cancer was in my bones. Like, you think anything that happens to your body, you have this high alarm for, oh my God, what is it? Right. So I think in some ways that's a good thing, because you now are looking
Right.
at and saying, okay, I need to call the doctor. I need to be on top of it, whereas before you may have ignored it, but now you're like, okay, what's going on?
Yeah.
And we
And,
have to
and
take
one
those.
more thing that we can mention, Ricky, and you say this a lot. You think your stress caused your breast cancer.
I
Doctor, you
know I
didn't
was going
use
to
the
go there.
words, right? Allostatic load, right? But can you talk about the research that's being done
Mm-hmm.
in the evaluation of the impact of stress on
Mm-hmm.
Black women's bodies? Can you just whatever a little peripheral stuff? I know you probably know more than you got time for, but give us a little taste of it and talk about why mental health is so important.
Mm. Okay. So where do I start? Stress. I'm gonna start from here. In a clinic setting, generally, in most clinics, you find that you people will use something called the distress thermometer. So I've heard, I know within our clinic here they do it, and it's just like, where are you here? 1 to whatever, and then
Like
talk
that
about some of
pain
the
thing
issues.
is a 1 to a 10,
Yep, it's
right?
just like, yeah, it's a distress. It's a clinic. So there's a clinical cut point, so they should know, like, if you hit this point, that you're considered in distress. And not enough work has been done in that. So I know, like, at our health system, we have data and data and data that need to be analyzed. I'm sure other ones do. Now, that's not the scale that I tend to use. And so there's a scale that I tend to use, looking at what people call perceived stress, which to me is actually your stress. Because if I ask you some questions about where you are with regard to your stress, are you having trouble falling asleep at night? Are these things on your mind keeping you from getting your tasks done? Um, there's more work, a lot more work. And I will say this, Dr. Mo, there's a lot of work in cardiology. So cardiology, they beat us to this. Like, a long time ago, cardio oncology is brand new. And so now we're like, hey, we're in here, we're doing the same thing. So that's why I work with people in cardiology. So we're looking at stress, but I think the important part now is, and depending on the populations you study, stress, anxiety, depression, there tend to be differences I've seen, and they're not always the same with regard to differences by race. I have seen where Black women report higher stress in breast cancer survivors than white women. Um, I've seen the reverse. I've seen, with regard to anxiety and depression, I've seen where Black women report more, and I've seen the reverse. So we call that mixed. We can't really say, uh, you know, but I think what's most important now is what we start to look beyond the, like, we're reporting the stress and understand what's contributing to the stress. And then how is that stress then impacting our bodies biologically? And I think that's now what's happened. What we're starting to see more studies are. So we're understanding what I call our social determinants of health, I call social drivers of health, trying to really understand how women's experiences with everyday stress, women's experiences with transportation, finance, like being able to pay your bills, food insecurity. One of my colleagues just published a paper in JAMA that was looking at neighborhood safety and what's in your neighborhoods and how that can contribute to of your risk of heart disease. But these are the things now that I see that that the work is going towards. The problem, though, is that this is why it's important that researchers and clinicians work together.
Yeah.
Because this type of information is not really captured at the clinic level. It's captured in research studies. And so how then do we make this information helpful to women as they're going through treatment? And that's what we like to call translational. And so research always moves like this, all slow. And so we're, hopefully now we're starting to see, there's a lot of investment in this work on stress and the impact of stress. And so hopefully we'll be able to start to mimic what we're doing in research in the clinic so we can truly see some outcomes. But stress is a thing. It is a thing.
I really swear that it caused my breast cancer. And, I had to learn that how to feel it. So I now can feel stress at a cellular level. And I've developed these filters for stress. Everybody knows what they are when I call somebody an asshole or think about that. Think about that word, they gotta go. But I kind of look at it like those are cancers that I have to get rid of. You know what I mean? But I feel it. It's like when you're like in the car and you're like, and you've like, that's stress. And so you have to figure out what are your stress filters and learn them as a patient so you can walk away from it. You know what I mean? And so, use my filter if you want to. It works every time.
And anxiety and depression and stress manifest differently sometimes in Black women because we're used to just powering through. Like haven't learned, right? You learn what your trigger is, but for
I
a lot
had to learn the hard way.
They don't realize that they're snapping at people and they're irritable and that maybe you're having trouble sleeping. Maybe there's signs and symptoms of the way stress impacts your body that we can sort of learn to pay attention to. Maybe you overeat, maybe you don't eat at all. Maybe, something changes in your behaviors or even just, again, like you said, at that cellular level. But it's important for people to realize too, that this is not just a phenomenon that happens to women, right? Like stress in men and stress in men and cardiovascular disease is a thing. I don't know about the associations with, say, things like prostate or colon cancer, but what I do know is that Black men as well are under a tremendous amount of stress that they are not talking about and not encouraged to talk about. So we definitely talk to our men about this too.
Really?
Yeah, I did see some
panic attacks. They have panic attacks and they exhibit differently.
Yeah. Oh yeah.
Because I think as women, we learn to cope because we got to do the stuff. What are we going to do? Right? Yeah. Not go to work.
We have our sister circles. We talk it out, right?
Yeah, we talk it out, and the men just internalize it, and then they flip out, right?
Yeah, but sometimes even that coping is not good on our bodies, and so there's something called vigilant coping that they talk a lot about, particularly with Black women, when it's like you're trying to prepare yourself to go into a situation. So I'm gonna give you an example. Anytime, and it's bad, but I know you all understand. There have been times that when I change my hair, I don't want to go to work. Because I already know when I walk in, somebody's gonna say something, and I'm like, Lord. And so we think about that's just that I would consider that a mild example of vigilant coping, but it happens. If you're going to go into a room, if you're a woman and you're going to go into a room of all men, and you're like, okay, that way of you trying to prepare yourself and get yourself prepared for the situation, that's stress. So that's a coping mechanism, but it's like a maladaptive coping mechanism where it's like it's a poor coping mechanism. Like we're probably causing more harm to ourselves. And again, it's not like it's our fault. It's actually the way society and things are. But that is, when we talk about coping, you got to remember that sometimes it's not the best.
Yeah, but you stress, right?
Yeah, you talk about hair. It could just be your job. You could be like, sit outside the job thinking, okay, what am I going to walk into? And I used to do that with my marriage. I would sit at the top of my driveway like, okay. And I just give myself 5 minutes before I would go in my house. just to prepare myself for what I was going to be dealing with that
Yeah.
day.
Yeah.
And I got stress. I didn't think about it then because I had to go in the house. Now I'm like, I don't have to go in the house.
Yeah.
Go to another house.
If we think about, so we're talking about stress and coping. You know, one of the things that I've seen more work in, especially within survivorship, is the thought about integrative health. And so treating the whole person, and thinking about like how and I know, again, I will always have the caveat, I am at an academic medical center. So we have a survivorship clinic here. We have integrative health where you can do mindfulness and yoga and so these are but these are strategies that will potentially help individuals as they're going through the journey. But I'm gonna go back to what Dr. Mo said in the beginning. Most individuals are not treated at academic medical centers.
Right.
So the question then is, how do we make these resources? How do we push to make sure people have access to these type of resources that are helpful with regard to going through the treatment journey and even on? So I think that's something
we have a great partner. I just put it in the comments. Unite for Her, uniteforher.org, and I put their Facebook page and their website. They're out of Philadelphia, but they provide $2,000 worth of integrative services to patients.
Wow.
While you're going through treatment. And they have food, they have grocery baskets, they have yoga, they have cooking lessons, they have Reiki, they have all kinds of things to help you deal with treatment. And they are an amazing organization, and it's like free. And you just go to the website and sign up. Mo works with them. We love them, and they are just an incredible resource for stuff to make you feel better.
I'm a big fan of Unite for Her and the focus on integrative wellness. They do wellness days here at my farm. And so we do wellness retreats where you can come and you can experience those different modalities. You can take a cooking class. You can learn about, yoga, about meditation, we have a new trauma-informed and a pain specialist. It's yoga that's directed at chronic pain. And that'll be at the next wellness day on May 4th. But Unite for Her is a tremendous resource. And the science really does have to catch up to this, because it's something that I think we have always believed, and we as a people have always believed, that food is medicine. And we want, third question I get asked, am I going to die? Do I need chemo? And how can I change my life, doc? What can I do? What can I do holistically? Right? How can I get off these pills? Is there anything that I can do, one, as an alternative to chemo? What can I do from a holistic standpoint? But how can I just change my life? I want to live healthier. And you know what doctors say? Eat good food, get good rest. I don't know, look at your labels and count your calories. And it's so much more to that. And Michelle, I see you in the chat. We got a comment, and she asked if we would talk about inflammation. And she's saying inflammation comes from what we consume, and inflames the body, causes disease. Can we talk about inflammation and heart disease a little bit? You want to share just a little bit?
So yeah, the work that I've done hasn't gotten down to that level, but I think my background is in pathology, so I think I know a little bit about inflammation, like in the way we assess that. So we know that not only, like you said, Dr. Mo, like the type of food, there's foods that can contribute to inflammation. There's medicines that contribute to it. There's definitely a link between stress and inflammation. And so that is a whole, the way that we deal with stress. We talked about allostatic load and how different levels in your body, your cortisol, other levels may fluctuate, and you may your body may respond in a way that you may, what we see or feel as inflammation. I know that there have been reports, and Dr. Mo could probably speak a little bit more on this, of inflammation as a result of particular cancer treatments. And I only know that from interviews. So that's not like numbers data that I've done. This is just talking to different women and what they tell me they've been experiencing. And so I don't know if either one of you know of or know more information about that.
So what I know of inflammation is more on the risk factor side of things, because there's a whole cellular cascade that happens. So when the body is inflamed, it's under stress. And the way I explain this to people who don't know anything scientific is this: if I gave you an essay to read, right, and push you out on stage and say, here, read this, when you didn't get to practice it, you didn't get to look at it before, you're going to be under stress and you're going to make mistakes. And what happens in the body as a result of the stress from foods that we eat, from environmental things, right? At this very cellular level, higher inflammation in the body causes our insulin resistance. So now think about people who have like the polycystic ovaries, right? Your doctor told you got PCOS, your menstrual cycle is irregular, and you have dysfunctional bleeding. There's inflammation that's in your body from that. The thyroid can be inflamed. Inflammation in our gut, right? Pooping every day is a thing. And when we don't, the bacteria gets into the bloodstream. And that travels through the body. It causes inflammation. And there's this concept of something called the tumor microenvironment. What's happening around the tumor in the breast tissue, around that tumor? Something's happening. And inflammation is feeding that tumor and creating a nasty little garden to grow. So there's all these different reasons, never mind like inflammation in your joints and lupus and arthritis and stuff. But at the very cellular level, inflammation causes the cortisol levels to go up. You cause you gain weight, causes you not to sleep. It causes your nutrition to go wonky. It causes your pancreas to go wonky, and all that stuff it's just, we got to work on as a people, decreasing the cellular stress and decreasing the inflammation for sure.
But it starts with recognizing it. You know, I think that, you know, we are all trying to be badasses and we're just trying to get through the day and get stuff done. And we have so much on us as mothers, as wives, as single moms, as workers. You know, we're all working like dogs and everything that we do, right? And we have to figure out, okay, is something wrong with me? Am I just sucking it up because I have to get the kid fed? Or at what point do I need to address this? And I think we see, you know, that's how we see people getting late diagnoses of breast cancer because they have ignored something for some time, or they've ignored getting a mammogram. And so it starts with really taking care of ourselves as women.
It does. You know, one thing I want to say, Ricky, a lot of what we talked about is very much so, and and I'm going to say this as an aside. It's important because we have to feel empowered to be able to speak up. But there has to be something done on the provider institution side too. Because the onus or like the responsibility can't solely always be on us. You know, people go to school for a real long time, and I assume they get paid good money.
They get stupid though. They get dumb. I'm telling you, the smarter we get, something happens.
But sometimes, you know, and it's like providers, sometimes it's like, talk about what you don't know so that we can make sure you know it. So even when we talk about this cardio oncology, there's still this huge disconnect. There are providers who are not as aware of this as they want to say that they. Yeah. And so we, you know, a lot of the work that now I try to focus on is like, what can we do at the survivor level? How can we, you know, what kind of behavioral modifications can we make? You know, what kind of awareness and knowledge and all that. But then on the other side, it's like, let's understand what these physicians know. Let's understand how they communicate this information. Because we had just recently, we wrote up this short abstract. So this short brief about these interviews we did with Black and white women with breast cancer. And we wanted to ask them questions about just when they were on treatment. So all of these women receive treatment that could potentially impact their hearts. And I'm like, let's talk about what your provider talked to you about. What your doctor talked to you about. What did you feel? What did you do? All of this. And it's interesting when you start to talk to people, they're like, I think they gave me some papers about something. But, you know, I was just diagnosed and I'm like, cure my cancer. They talked to me about my heart. But again, it's like the focus, and rightfully so, is like cure my breast cancer. Let's focus on that. But I think there is a way that we can weave in the impacts of things, just so people are aware. Because everybody wants to be aware, you know, whether it's something I can deal with right now or down the road. Awareness is important. And I think
it's on my radar screen, so I can be looking out for it. Right.
Exactly. So I think that is, I'm like, yes, we want to make sure people know to speak up for yourself. And these are some of the signs and symptoms. And on the reverse side, as we're advocating, we need to make sure that providers in community settings, academic settings are aware. Because there are studies now that show that older women with breast cancer are more likely to die from cardiovascular disease than they are from breast cancer. So
Mhm.
cardiovascular disease after breast cancer is truly something we need to start really thinking about. And there are, like Dr. Mo says, some of this, these changes that we see during treatment, some of them are reversible. So they have shown that women that receive like Herceptin or trastuzumab, that generally speaking, if they catch it like in an echo during treatment and they stop the treatment for a while, it will reverse itself. But some from the chemo is irreversible. And generally by the time those changes are caught, now it's like, can we go into maintenance mode to make sure that it doesn't get any worse? So we have to think about it from multiple
Yeah.
levels.
We need
We
to write an
do.
article for Black Doctor about this, Mo.
We should, absolutely. And really don't throw the baby out with the bathwater. This is a very nuanced conversation where I don't want to see people choosing, well, I'm worried that chemo is going to affect my heart, so I'm not going to do chemo.
Yeah.
That's not what we're saying here.
No.
And I think it's really important for you to recognize that, because it could easily take away, oh my God, see them drugs, I knew they had side effects. I knew it was going to cause heart. Yeah, but benefit risk, right? It's a conversation and it's an individualized, personalized assessment. It's why we call it personalized medicine, because we're getting to the point where we need to do that more and more. Because we're learning that we can treat people less. We can do less surgery, do less radiation, maybe do a bit less as we age, we get older. But for people who are young, for people who have aggressive cancers, don't take any of this for
Don't
granted.
take it now.
Yeah.
And
just get your team, right?
You can treat the heart disease. So it's not an and or.
Get you a team and learn what questions to ask and learn how to monitor for yourself. But you're right, Doc, that the clinicians really do need to be more educated. And some of this comes out of the meetings that we can't always make it to, because, you're working, you're operating, you're seeing your patients, and you can't make it to San Antonio every year, and the late breaking abstracts and all those things, right? But there has to be a really an ongoing education. And it's okay to ask your doctor, what do you know about the heart side effects of this? What should I know about the heart side effects? That's the main question. You can say, well, what do you know about it? And you say, well, what should I know about it? And is there anybody else I should talk to about it? Anybody who specializes in this?
Exactly.
And those are okay questions to ask.
Yeah.
I brought this up before we went live today about my now deceased, what do you call it? I call her my mother-in-law, Nate's mom. And she was like in her late 80s, but she had heart disease for 10 years probably. And so they attributed everything, any symptoms. She has a bad heart. Well, first of all, the word bad heart, what does that mean? And I would say, well, what do you mean bad heart? What does that mean?
It's like the sugar. It's like sugar.
The sugar. It's like the sugar, right? She had a bad heart. And so anytime she sneezed or any symptoms she had for anything was she had a bad heart. So when we're talking about COVID, she had a bad heart. And she died of colon cancer. And she probably had colon cancer in her body for a few years before it took her out. But they attributed her stomach pain or whatever she was have symptoms from the colon cancer to a bad heart. But again, where were her doctors? Where were the providers? Were they just going? She's going to the doctor every month for her heart disease. Like, who's looking at her body? And I think that we as Black people sometimes just start to accept what we're told and not question. I mean, I always use my analogy about, we live in this world of health inequity, and we're not going to get it until equity until everybody practices the golden rule. And that's why we tell patients, you go back to that doctor and you say, I want whatever you're giving your mama, your auntie, your grandma, your daughter. That's the treatment I want. Like, I want the good stuff. And I don't want the drive-by visit. I want the filet mignon visit. Do you know what I mean? I think, why Mo, we love her so much is she says, I'm going to treat you like family. And that's what we have to demand. From doctors. Okay, how would you treat your family? How would you act differently? Are you doing the best you can do for me?
That's right.
And somebody in the chat, Sharon, I thank you for saying this. She said, we need to take somebody with you to the doctor. And, especially if you have limited understanding, if you're afraid. The studies show that when you have a family member with you, the doctor spends on average 2 minutes longer in that room. And in that 2-minute time, in that 2-minute conversation, all it takes is an additional 2 minutes to get people to consider life-saving treatments that are aggressive that they might have turned down the first time or clinical trial, right? 2 minutes isn't it's a long time in an exam room when you sit there with no top on, right? Waiting for the doctor to tell you all the things. But those 2 extra minutes can really save a life. So bringing somebody with you or having somebody on FaceTime, have them on speakerphone, come in prepared. And Stephanie, I hear you. It's not to just put all the responsibility on the patient, but at the end of the day, this is your life, and you got to make
Yeah.
sure that you got that team that you need to advocate for you if you're not able to advocate for yourself. Because once you hear cancer, you don't hear much else. It's really hard. And so, having those advocates with you, you need one, call Ricky. She'll find you one.
I'll
She'll
find
be
you
there
somebody. I'll go
with
FaceTime with you, whatever. I've been thrown out of a few doctor's offices. I don't have a problem with it, but you really do need to have a buddy with you, because you just don't hear it all, and you're scared, and you don't feel well, so you got to have somebody kind of back you up, and we're happy to we'll get you somebody to go with you.
Yeah, I'm so glad someone brought that up, because one of the things we talk, especially now in the last 2 years, all you heard about social determinants of health, social determinants of health, and how they impact outcomes. What most people don't know is that social support is a social determinant of health. And they
say
have
that
shown,
again. Say that again.
Say that again. Yes.
yeah,
Yes.
social support is a social determinant of health. And studies have shown the importance of having some type of connectedness, some type of support, whether that's what we consider like support that we can touch and feel like a person, or whether the social support is some type of information, like good information that you have. Social support, good, what you perceive as good social support can impact your outcomes in a positive way. So, that should not be taken lightly. That's just as important. It is just as important as your transportation, just as important as your insurance status. All that social support is part of the social determinants.
And that also speaks to, don't hold this stuff in. We have so many of us. I don't tell my family. I'm not going to tell anybody. Don't tell anybody I'm sick. Don't tell me I have cancer. You can't do that. You have to have, and if you don't feel you have support, we have 2 support groups a month. Come on, talk to us. We'll help you out. You're not alone. You are not alone. You are not alone. I can't say that enough. You guys know where to find me, Ricky at touchbbca.org. You are not alone. Don't try to do this alone. You can't. And you don't need to. You don't need to. We have so many support systems. So if you don't have it in your house or in your family, or, and your family's better off when you tell them, because you could have something that's genetic that could pass on to them, to your kids. You could have something that maybe someone can share with you because they had it. So don't not talk about it with your family and friends. And if you need a buddy to help you even do that, we're here for you. So.
Well, Dr. Neetha, we're going to invite you to kind of give us the wrap up. If there were some things that you wanted people to take away from this conversation, what would those things be? Give us some top 3, top 5, whatever you want to share.
Okay. So the one thing I will recap is that it's important to remember that all treatment comes with their side effects, and that heart disease is starting to become one of the leading side effects of certain treatment. And because I don't believe in ending down here. So one of the things we didn't talk about is like, we are seeing promise in things. So I don't want people to go away, like Dr. Mo saying, oh no, like that chemo, that this, radiation was one of those, especially to the left, right where your heart is, was one of those that was like a major cause of heart disease. And then, I believe it's probably some research and trials that recognize what I think they call like deep inspiration hold. I think so, like when you go and they tell you to hold your breath, and then they do the radiation, and because you're holding your breath, it's further away from your heart. And so they're showing that is a way to help to minimize your chances of getting heart disease. There are studies now that are looking at, even if you have certain chemo and therapies, if you're exercising during your treatment, how it could potentially positively impact your heart. And so I will say my last point to that regard is we are making strides. We know that these treatments are potentially life-saving treatments. And so clinical trials are so important. And even when I say clinical trials, it might not even be what we're used to of like, oh, you need to take this treatment. It might be, we have this exercise trial that we're running during your treatment. And this is, and I would say, learn about it and consider it, because this is how we figure out ways to rid that side effect. This is how we figure out ways to protect the heart. So I always like to end on a yay for clinical trials, learn about them.
For that. That's our mantra. And if you have any trials that you are doing and studying, let us know, and we will, we would love to help you get some patients in the trials. Or if there's trials I can do as a survivor, sign me up. And I got
love it. It's an important point, right? Not all trials are drug trials, because there's a
Right.
really big misconception that clinical trials are just, being a lab rat for those drugs. But guess what? You can be you can be a hamster on an exercise wheel.
Yep.
Yeah.
But
Well, I've
it's
done 2 trials about stress already.
see, there
Right.
you go. And I'm making light of the situation, but the reality is we all
Yeah.
got to learn how to move these bodies and how to love
That's
the
right.
ones we got, because these are the ones, right? No matter what is happening to you right now, this is the body that got you to today, is going to
Right.
get you to tomorrow.
Right.
So we have to make some changes, make some steps, small incremental steps. You really just got to nip away at the behaviors, and it is possible. And if you need a trial to help you do it, guess what? Dr. Arnita probably got a trial for you. She might have
Oh, it's going to be
something
Yeah.
for
coming
you.
your way soon.
We
Now
can,
that Ricky
we
said
can
that,
help
that's all
you
she had
with,
to say.
I
can
got
help you with the
you.
research too,
I got a trial for you, Dr. Nithya. Ricky, I got one for you too. We're going to talk about this, and we are going to
Okay.
collaborate, and Touch is going to do a trial on this particular topic. So I'm excited.
We're ready. Yeah.
Yes. Well, we hope it's been relatable and reliable and real. It's what we do every Wednesday night here on blackdoctor.org. And we're thankful for the platform to do it. Wow.
We're thankful for Black Doctor, for Amgen, for Novartis, for all of our sponsors. And we're happy to do this every week. Every week.
And for the person who asked, are they going to replay this
Yeah.
for the live? This lives on blackdoctor.org's website, on their Facebook page. It lives
Lives
on
on our
Touch the Black Breast
Facebook
Cancer
page
and YouTube.
and
Right.
YouTube. So I'll put it up on YouTube in the next half an hour on at Touch BBCA. So it'll be on YouTube. You can always reach out and we'll get you something.
And if you share it on your Facebook page, it can live on yours too. And other people can see it, they can share it, they can click and replay it any time. So this is evergreen. It'll always be available to you. And we hope to see you next Wednesday night on blackdoctor.org, 6 p.m. Eastern time for the Doctors In.
Doctors In. Love you, Mo.
Oh, I love you too.
Thank you
I
so
like
much.
that. Yes.
There it is. Happy New Year.
Happy New Year. Thank you so much. Love you guys. Bye, Mo. Love you, Mo.
Thank you. I'll see you.
Bye.